topic we are discussing today is shock. In normal circumstances, the cardiovascular system ensures that an adequate and constant supply of oxygen and nutrients reaches all cells in the body and that metabolic waste products are removed. Homeostasis is maintained by the four essential circulatory components, which are blood volume, blood flow, vascular resistance, and the myocardial contractility. When one of these circulatory components fails, the other compensate. Shock develops when this compensation fails. So if the compensatory mechanisms fail, the cardiovascular system will fail to function, resulting in a state of circulatory shock. Now we can divide shock into three major categories: hypovolemic, cardiogenic and obstructive, and distributive. Hypovolemic shock develops when there is loss of blood volume. Hemorrhage is the most common cause of such shock. Cardiogenic shock is when the heart fails as a pump. Obstructive shock is when a mechanical or physical obstruction impedes the flow of blood, usually from the left ventricle. Distributive shock is when there is widespread vasodilation and decreased peripheral vascular resistance. In this case, the circulatory blood volume usually remains normal. Distributive shock can further be subdivided into three types: anaphylactic, septic, and neurogenic. Anaphylactic shock follows a widespread allergic reaction that can lead to severe circulatory collapse within seconds. Septic shock occurs as a result of widespread infection. The release of toxins into the bloodstream results in massive vasodilatation and hypotension. Neurogenic shock is a rare type of shock which can occur following major brain or spinal trauma. Can also occur due to emotional trauma, severe pain, drug overdose, or incorrectly administered spinal anesthesia. No matter what type of shock we are talking about, in case of distributive shock, the common denominator is vasodilatation. Okay? Once there is widespread vasodilatation, that leads to decreased peripheral vascular resistance, which causes decreased venous return, leading to decreased cardiac output and leading to hypotension. This would cause decreased tissue perfusion and, as a result, impaired cellular metabolism. Let's look at these three subtypes of distributive shock in more detail. Anaphylactic shock is very common in Australia. So basically, Australia has the highest prevalence of IgE-mediated food allergy in the world, with a staggering 10% of infants with challenge-proven food allergies. And of greatest concern, there's an increased associated fatality rate. What can cause anaphylactic shock? There are many triggers. Antibiotics can lead to this. You may have heard of penicillin sensitivity. Anesthetic agents, muscle relaxant, can cause this. Aspirin, non-steroidal anti-inflammatory drugs, immunizations, blood products, intravenous radio contrast media, latex, food allergies, for example, shellfish, eggs, nuts, dairy products, and last but not the least, insect bites. In case of an anaphylactic shock, the signs and symptoms could be a sense of impending doom, anxiety, restlessness, altered levels of consciousness, severe hunger for air, bronchospasm can develop, and dyspnea. Stridor, which is caused by laryngeal edema, is usually a very grave sign. Urticaria or hives, pruritus or itching, rhinitis, conjunctivitis, abdominal pain, vomiting, diarrhea, edema of the lips, eyes, hands, neck, and throat. Now, in case of anaphylactic shock, the intervention should be offered as early as possible before bronchospasm and stridor sets in. What about septic shock? It occurs as a result of widespread infection, most commonly associated with gram-negative and gram-positive bacteria, which may be present in the blood, which is called bacteremia. And the release of toxins into the bloodstream causes massive vasodilatation and as a result, hypotension. Sepsis is the systemic response to infection and shows evidence of a widespread inflammatory response. Early recognition of sepsis is imperative and includes looking for sources of infection, measuring physiological signs and symptoms to identify potential organ dysfunction. Now, who are at risk of developing sepsis? The very young and the very old, people who have impaired immune system because of illness or drugs, history of recent surgery, any breach of skin integrity, intravenous drug abusers, people with indwelling catheters, women who are pregnant, have given birth or had a termination of pregnancy or miscarriage recently. Let's look at some of the manifestations of different types of shock. Hypovolemic, anaphylactic, and septic shock. There will be tachycardia, okay? And there will be an increase in respiratory rate. But in case of neurogenic shock, you will see bradycardia instead of tachycardia, and the breathing may be rapid and shallow. Looking at the blood pressure, there will be hypotension. In case of urine output, there will be decreased urine production. In case of sepsis, there might be an increased urine output initially, but eventually there will be oliguria. What about body temperature? You will have temperature within normal range. However, in septic shock, temperature is initially raised. In case of neurogenic shock, the temperature regulation is disrupted, so patient may present with hypothermia or hyperthermia. What about skin? Usually the skin is cool and pale, but in case of anaphylactic shock, the skin may be cyanosed and you may find swelling all over the skin. In case of septic shock, skin is initially flushed, but eventually it also becomes cool and pale. All right, what about mental state? Mostly patients are restless and anxious, but in case of neurogenic shock, the patient may be unconscious. It could be due to the reason of neurogenic shock, if that is fainting or head injury. Now, what about the pathophysiology of shock through various stages of its development? The first stage of shock is a compensatory or non-progressive stage. The second stage is progressive or decompensated stage. Third one is irreversible or refractory stage. Now, what happens in the early stages of compensatory shock? A set of compensatory mechanisms are initiated in an attempt to restore homeostasis and maintain blood flow to vital organs such as the heart, brain, and kidneys. So, under neural mechanisms, baroreceptors and chemoreceptors, which are found in carotid sinus and aortic arch, they detect the reduction in blood pressure and they send impulses to the vasomotor center in the brainstem, which causes increase in heart rate and respiratory rate. Under the hormonal compensatory mechanisms, there is release of catecholamines, which increases the heart rate and also the force of contraction to improve cardiac output. The coronary arteries vasodilate to increase the blood flow to the heart muscles. The rate and depth of respiration increases so that there is good gas exchange in the lungs. Kidneys release renin when they detect a drop in blood flow or blood pressure. And renin causes conversion of angiotensinogen into angiotensin 1, which is then metabolized into angiotensin 2, which is a powerful vasoconstrictor. And the presence of angiotensin 2 leads to release of hormone aldosterone from a renal gland, which causes reabsorption of sodium from the renal tubules. This causes retention of water, and which could then cause an increase in blood volume and blood pressure. Stimulation of posterior pituitary gland causes the release of ADH hormone, which again increases reabsorption of water by the kidneys. So the blood volume may expand and blood pressure may go up. Because of the action of ADH, patients in this stage of shock may present with oliguria, which means very low volumes of urine, or even anuria, no urine formation at all. Now, the third compensatory mechanism is chemicals. So chemoreceptors located in the aorta and carotid arteries will get activated. They will send signals to the brainstem, and the rate and depth of respiration will increase. If these compensatory mechanisms are working together in harmony and they are effective, patient may not progress to stage 2. But if these compensatory mechanisms begin to fail, the patient will move to stage 2, which is the progressive or decompensated stage of shock. In this stage of shock, if clinical intervention is offered, patient can be recovered. But once stage 3 sets in, which is irreversible or refractory stage of shock, no matter how much clinical intervention you offer, the end organ damage has already occurred and you will not be able to cause any improvement in the condition of the patient. The patient usually dies within the matter of few hours. Now, clinical findings in shock. So early findings will be increased respiratory rate, increased heart rate, you have peripheral vasoconstriction coming in, and then as a result of that you will find there is pale skin, there is cool skin, there are weakened peripheral pulses because the blood is being directed to vital organs. So blood flow to skin and other non-vital organs becomes less and less. When the shock continues and there is end organ perfusion failure, altered mental status, and decreased urinary output. With compensatory mechanisms fully engaged, you see these clinical features: increased respiratory rate, increased heart rate, pupillary dilatation, pale, cool skin. When compensatory mechanisms begin to fail, then the blood pressure will begin to go down. There is falling SpO2, bradycardia, coma, dysrhythmias, and of course at the end, death. Now, how do you manage different types of shock? There are some general principles which are applicable to all types of shock. So the initial treatment is based on restoring hemodynamic control by correcting the circulating blood volume. Further treatment then aims to restore tissue perfusion to all organs and to achieve a correct fluid balance. And of course, you will try to correct the underlying cause. You'll give patient oxygen inhalation. But the oxygen therapy, although is given, it may not really help because in many cases it is not the oxygenation of blood which is at fault, it is the delivery of oxygen to the tissues which is reduced. So you need to treat that particular cause. Let's look at some specific treatment options for different types of shock. In hypovolemic shock, a patient should be in a supine position, so a good blood flow is maintained to the head and brain. Fluid replacement, in case of hypovolemia, you can give isotonic crystalloid solutions. You can give colloid solutions as well. In hemorrhagic shock, the ideal option would be to replace blood by whole blood packed RBCs. If that is not available, isotonic crystalloids can be given. In case of anaphylactic shock, maintain airway. Remember, one of the grave signs of anaphylactic shock was laryngeal edema and stridor. So you want to maintain airway. Ventilation may be required in some cases. Epinephrine is given in anaphylactic shock. IV fluids, antihistamines if there is allergy, steroids, beta agonists, and pressor support if the cardiac muscle begins to fail. In cardiogenic shock, nitrates can be given. Morphine or fentanyl sometimes helps. Inotropic support is required. Definitive therapy if it is due to a massive MI, for example, fibrinolytic therapy, PTCA, cabbage, ventricular assist device, or in extreme cases, even cardiac transplant if possible. What about neurogenic shock? Fluid resuscitation with crystalloid solutions. Look for other causes of hypotension. Consider vasopressor support with dopamine or dobutamine. Transfer patient to a regional spine center for specific treatment. What about septic shock now? IV fluids, pressor support may be required, and of course empiric antibiotics. Removal of source of infection if possible, and if it is due to a gram-negative infection, anti-endotoxin antibodies can also be given. So in summary, due to the life-threatening nature of shock, it is essential that the condition is recognized and treated in a prompt manner if inadequate tissue perfusion and subsequent organ failure is to be avoided. Close monitoring of vital signs is needed to ensure the early detection of any deterioration in the patient's condition. Common interventions include oxygen, fluid, and drug therapy, and wherever possible, treat the underlying cause. All right. So with this, I come to the end of this topic, and I hope I was able to provide you a basic understanding of circulatory shock. Please read the chapter for more detailed insight into the topic. Till next time, take care. Bye-bye.